and isolated and hopeless with the illness. And I think I'd commend all of you to read this personal journey that was in the BMJ. So this was she was a psychiatrist who'd had anorexia when she was 12 or 13. And she said, if I have to describe my anorexia in one word, it's isolation. So this sort of indicates, and we know how isolation and loneliness is so toxic to well-being. And so the family offer a way to bridge connection to others, because they have a high degree of commitment, tolerance, and accessibility to break this sort of desert of ice. And we were very interested thinking about what happens to interpersonal relationships with anorexia and trying to manage the anorexia. And so I did a joint piece of work with co-authors who'd all had an eating disorder themselves, and many of them also were either doctors or psychologists. So they had the two hats, being able to have their personal experience, but also their education about psychology and medicine. And so we're thinking about what happens on inpatient units and the sort of social changes that easily happen. And this led to us thinking about these animal metaphors which described some of the unhelpful interpersonal styles that developed on hospitals, but also we realised developed at home. And parents themselves really are so eager to help, but they always say, give us information and tell us how to do it. So these are studies that ask them their views. So this is the sort of, at the top we have all these emotions that we gave these animal metaphors to. We didn't immediately do that. It took us time working with carers. But there was often people denying there was any problem or avoiding it, the ostrich-like head in the sand. Or there was sort of criticism of the individual, blame, a rhino response, getting aggressive, or accommodating and enabling, this kangaroo caring approach, or being very sad and angry and having all your emotions so transparent like a jellyfish. So those are the things we often see, both as inpatients but also at home. But of course the underlying emotion are fear and terror, what's going to happen, feeling helpless, the person doesn't want to get better, how can we help, hopeless, feeling resentment, why has this happened, this is awful, is it to get back at me, there's always those feelings of that people could do something themselves, and shame. So a big emotional melting pot. And so we've found that being able to talk about these animal metaphors takes a bit of the sting out of it. It makes it a bit more amusing, because we're saying these are common reactions, they happen to us as professionals, they'll happen to you. And so that allows families to think about it and understand the important thing that because of everybody developing these different styles, there's often divisions within the family. So families put in a huge amount of effort. This is just work from some of our studies with families. This is in adolescence, so this is a series where they're about 16, they've had illness for nearly 2 years and a BMI of 17. So they're usually living with the carer. And the mother is giving about 2.5 hours a day for food and emotional support, and the father giving an hour a day. And the adult patients there, they are 26 years old, duration of 7 years, lower weight, still living at home, not moved out. Some have got partners. And again, the carers are giving about 2 hours of care. So it's a lot of work, and a lot of work for a long time. And the sort of things that make carers cope or not are related to these three main domains. So how stressed a carer gets depends on illness factors, their own carer factors, and society factors. So the illness factor is very tough when somebody is so overtly ill and doesn't accept the sick role. And with these symptoms being so pervasive, every meal you're seeing the person avoid eating, so 3 times a day at least, so they're very intrusive. And then we get all these added emotional and physical problems from prolonged starvation. The carer factors, I've talked about all the time burden. There may be beliefs about the illness that they failed, they did something wrong. They may sort of get very bullied by the illness and accommodate to it, so that they sort of end up in a joint dance with the illness, sort of getting special food and allowing her only to eat half or whatever. Or they end up with these emotional reactions that we talked about, being critical or being overprotective. And society has problems. There's the stigma we've talked about, people sort of assuming that the parents may have done something wrong. Even with an NHS, the cost of treatment, having to have time off work, go for appointments, etc. And in other countries, it can be horrific. I've been to carers conferences in Australia. Carers are selling their house, they're losing their jobs. It's sort of devastating to have such a chronic, severe illness without a national health service. And the ignorance of others is hard, and the lack of knowing what to do as an early intervention. So this is a systematic review we've done looking at carers coping. We find that they have a lowered quality of life, high levels of depression and anxiety themselves, and they show these emotional behaviours. They either being overprotective or getting critical or hostile. So there's a lot of evidence about that. So, as I've indicated, these are enduring illnesses and things change. So often, in the early stage, and maybe in childhood, they may have had a daughter who shows perfectionist traits, and them, they may have all felt rather proud what a good girl she was. And then the illness develops, and then you're getting this shame, stigma, and panic happening in the first phase. And then later on, you get these secondary emotional problems, accommodating, enabling expressed emotions. And these images by Elise, again, I think are very illustrative of what happens. So here we see the carers sort of shackled by guilt, and they're taking up the burden of the eating disorder, whereas the individual themselves sort of is totally cut off from any thinking that there's a problem and she needs to do anything about it. So the enabling is where parents would, cover up. They might give money so she can go to a different supermarket to not go shopping locally. They may deal with all the bathroom things, etc. So they deal with all the negative consequences, drive her to school and that sort of thing. She's too weak. And then this one, it just shows how it's difficult to believe that parents are bullied by the anorexia, but I think this slide illustrates it well. So that, there might be the only eating alone in their room, and of course that has a big impact on the rest of the family. But that's one of them. But they accommodate in so many ways, getting special food, eating at special times, etc. So people find trying to get parents to carry on with the motivation to try and keep on helping the individual who's had the illness for a long time. It can be really tough for them. So what can we do? What have we done? Trying to share our skills that we use with these parents who are faced with a large burden. So we've been developing with parents and with patients themselves a lot of materials where we describe how to support eating and change all the other behaviours. We developed videos showing carers' reactions too, etc. So we think that there are these 3 different domains that we need to get across to carers. And we've developed these with patients and carers, as I've said. So the first thing is working together to really understand the illness. So when that family-based treatment was first devised, it was said that they were agnostic about the causation of the illness. They said, we don't know anything about it. Whereas I think that in the 40 years or so since that time, we have got a lot more shared understanding. And so that's important to work with carers, letting them know that. Then we need to suggest that maybe there are things that the carer is doing inadvertently that are just part of this reaction to the illness. We said how it happens on our inpatient units, and similarly it happens at home. These expressed emotions. And then the parents find that a bit tough because they feel, it's she who's got to change. Tell me how to change her. And it's not until the end that we're giving them more of the skills that they can use as therapy skills that we do. So we indicate that maybe they've got to do some changes first. And we indicate how this can be very useful because it shows to the individual that they're trying and they're modelling how difficult it is to change behaviours that have become very embedded. So we talk about the social problems. We mentioned that was a major factor that happens and might explain why, if you've had the illness for a long time, you don't get as well, you're not as responsive to your parents' emotional reactions or the reactions of other people, and you're cut off. And we see areas in many domains of social cognition. We see in recognition of emotion, the sensitivity to rejection and feeling alienated. They can't understand other people's points of view, what mum's saying. They think people are tricking them and not wanting the best for them. And also they have problems with their own non-verbal expressions. So this cartoon really illustrates some of the features that we get with people with anorexia nervosa. We know that inside they've got this anorexic voice that is talking all the time and sort of, I'm disgusting, how many calories in this, what's the food, blah, 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 blah. And they often don't tell you, but they overtly, but we know that this is going on. And yet they are not looking, they don't show fear on their face. If anything, they have a very flat face and looking rather calm. So it sort of seems, and also, how couldn't you be so frightened of food? Everybody eats. So it's difficult for others to have empathy for this. And I think these pictures by Elise sort of illustrate 2 aspects of this we can get. So we can either get this mask of this flat zombie-like face. And sometimes, though, you have this jolly, pleasing others face, and they'll sort of chat away, and seem as though they're having a good relationship with you, but will not take any blind notice of what you're telling them or what you suggest they should do. So they just twitter on regardless. So this pleasing exterior. And it's not just us in therapy it affects, it's their peers as well. Remember how the case sort of said she was isolated. And this one at university, talking about, so we talk about this lack of social cognition and the effect it has on other relationships. And she says, yes, I was known as the ice queen at university. And it wasn't just peers that found that off-putting, but the tutors also didn't like it, because when they were giving feedback, she'd look rather blank and aloof. And so they thought she didn't care. And I don't know, how many of you know the still face paradigm? Okay, well, perhaps we can have a little watch of it if it works. Doing it will work? Because this is just an example of what it's like when a baby has a mother not showing any emotions.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30-40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yeah.
So we show that to parents to sort of illustrate what it's, there's a little baby, sort of 6 months or whatever, and how painful that is for the baby and how they react. And we as adults have similar responses. We don't like it. We might not be aware of why we don't like it. It's very well recognised in CGI, because it's called the uncanny valley effect. More similar it is to human, but not quite human, sort of getting to zombie level. It really disturbs us and alienates us. And when people have been asked to interact, with a still face, people's blood pressure rises, and as well as them feeling they don't like the person. So we illustrate how that will be going on, and it'll be really difficult for them to be faced with this blankness and the difficulty getting appropriate emotional responses. And this really disrupts the interpersonal relationships.